Firstly, thanks to Dr. Sudhir for this opportunity and Dr. Ramesh Parmesar for this kind introduction. So today, it's a highly relevant topic, liver transplantation for HCC. It's now taking over the years, especially in the developed world. If affordability is not an issue, it is the treatment of choice and the predominant mode of therapy for hepatocellular cancer. We all know the statistics. Hepatocellular cancer is the fifth most common cancer worldwide, and it's the third most common cause of leading cause of cancer deaths. In fact, compared to other cancers, uh, other GI or other cancers, a patient with a liver cancer is most likely to die earlier. So it's a fairly morbid malignancy. And in India, and in fact in other parts of the world also, a late diagnosis is very common because HCC, it doesn't lead to any symptoms of the GI tract, or it doesn't cause jaundice until very late, or ascites. All those things, they come up very late. So the HCC diagnosis is actually quite late, and so a lot of patients are untreatable. The other feature about HCC is that it's mostly associated with chronic liver disease, commonly hepatitis B, hepatitis C, NASH, and alcoholic liver disease. So when you have these kind of problems, the surgery for HCC becomes very challenging because many times the remnant liver function is poor because the liver is cirrhotic. The remnant liver function is not good enough to support the patient's life, and many of these patients, because of their nutritional and sarcopenia and many other issues, they're not fit for surgery. The third concern in when there's associated CND is field cancerization. So obviously, like for example, if you take HPV, the DNA incorporates into the hepatocyte DNA and turns on the tumor oncogenes, leading to the liver cancer. So the query remains is, in one part they get a HCC and you do your surgery, there's a very high chance that they develop a subsequent foci of liver cancer in the remaining liver. Another important feature of HCC, it spreads distally along the portal venous radicals. So because of that, many times compared to what you see on the CT scan, what you see on the imaging, the tumor is more advanced because it gives off distal emboli along the portal venous radicals. So these are the challenges we face if you want to treat HCC like any other cancer. So obviously, logically, when you think about it, for liver cancer, because it almost 95% of the liver cancers occur in the setting of liver disease. So one treatment that can treat both the liver disease and the liver cancer would be transplant. Obviously, the liver disease, the decompensation is jaundice, ascites, the risk of GI bleed, plus the risk of the cancer and the subsequent field cancerization, any other spots. So the whole liver is replaced and the liver function is improved. So transplant logically seems like the ideal solution. So people, once transplant established in the late 70s and early 80s, people started looking at this transplant as a possible solution for HCC. Obviously, the pioneering work was done at the centers where the liver transplantation program was started, like in the Pittsburgh group by Starzl and King's College. So this is one of the earliest publications. Once transplant was established as a safe procedure, subsequently they looked at offering transplant to cancer patients as a solution. So the Pittsburgh group published in around, I think, 1991. So as you see in their series, 181 patients underwent surgery for HCC. They had these two groups, resection and transplant. But when they looked at the survival, 1 year, 2 year, 3 year, and even 5 year survival, you can see 71%, 65%, and 5 year survival was 32% for resection and 35% for transplant. So there was no significant advantage of liver transplant or liver resection for these group of patients. Those results were quite disappointing. I mean, all the effort and all the immunosuppression for transplant with no survival benefit would make it not a great modality. But even in that time, we had some clues, because if you look at the subgroup analysis at that time, Iwatsuki is a part of the Pittsburgh group. Then they did a later subgroup analysis of their study. You can see when they look at stage 1 patients and stage 2 patients, their survival was much more. So at that point, they were offering HCC to all patients without extrahepatic disease. The disease was limited to the liver. They were offering liver transplant. But when you looked at the subgroup analysis, the stage 1 and stage 2 patients had good survival. The stage 1 was 75% 5-year survival, and stage 2 was 68% 5-year survival. Similarly, other group, King's College also, they looked at liver transplantation for HCC, and there in 5-year survival, only 3 out of 93 survived. So the initial results were quite poor. With so the factors, was it the selection of patients, was the immunosuppression, all those factors were there. And at that point, in the early 90s, it was looked at, HCC was thought to be a contraindication for liver transplant, in fact. Then the Milan group had the seminal publication which totally changed our approach to HCC in liver transplant. So, initially the HCC, the liver transplant was thought to be an option for patients with liver cancer, advanced liver cancer. So, but these people, they showed that in selected patients. So, the Mazzafero group from the Milan group, the Milan criteria, all of us know. Their group had 48 patients, almost all of them with CLD. And they had strict criteria for eligibility. One tumor, so if they in the HCC on the imaging, if they had a single tumor, the tumor should be less than 5 centimeters. And if they had multiple tumors, they should have less than 3 tumors, and the largest of them should be less than 3 centimeters. So several of them had received neoadjuvant therapy, and so post-transplant, the recurrence-free survival was 83%, and only 4 of the 48% had recurrence. Of course. So it was a very good results. I mean, and then when they looked at the subgroup analysis, obviously, when many times what happens is in HCC, what you think of as the preoperative size of the tumor and the preoperative number of nodules, it can be more or less. Say, for example, what you think of a regenerating nodule can turn out to be a cancer, and what you turn out to be cancer can turn out to be a regenerating nodule, the size. All these things, there is the pathological reporting may be different from the preoperative staging. So when they looked at the data in their patients, in the patients who are within the criteria, within the Milan's criteria, tumor less than 5 centimeters, number of less than 3, the survival was 85%, and recurrence-free survival was 92%. While if the tumors were beyond this criteria, the overall survival was poor. So then the Milan's criteria started being widely adapted worldwide. It was validated worldwide by several studies by Asian, European, US, everything. It has been validated. It has been validated on pathology also. It's not just the preoperative staging. When they found, like I said, when the patients, when you think on pre-op staging, you think they are within Milan's, and then you sort of transplant them, and they're outside Milan's on pathology, they don't do as well as patients who are within Milan's on pathology. So it was validated on pathology as well. But obviously, the Milan criteria is very restrictive. I mean, you're hardly going to find patients with, these tumors. Of course, especially in the Asian countries, like the developed Asian countries like Japan, China, and all, and Korea, they have a very strong screening program. But the rest of the world is not that strong. So the criteria were very limited. I mean, the very few patients would be eligible for liver transplant. And then in the various studies, if you see over the years, we saw that it's not that all patients out of Milan criteria do badly. There are some subset of patients who are beyond Milan's criteria also who actually do pretty well post-transplant. So then other groups started looking at it in the West and in the East. So the UCSF criteria, again, the San Francisco University criteria, these groups, they published in 2001, and now these are the criteria which are more prevalent worldwide, which we are using. Of course, subsequently we'll come to the other ones. But they extended the criteria looking at the retrospective data of a single tumor up to 6.5 centimeters and up to 3 tumors, which the largest the largest should not be more than 4.5 centimeters, and the sum of the diameter of all these tumors should not be more than 8 centimeters. So with this, they had a excellent survival. Survival compared to the Milan criteria. 1 year survival of 90% and 5 year survival of 75%. So generally in the liver transplant for HCC, anything above 50%, 5 year survival is considered a good result, and that means transplant is an option. So by that criteria, the 1 year and 5 year survival by this UCSF criteria. So obviously with this criteria, they've extended a bit, even multiple tumors and single tumor, they've gone a bit beyond Milan's with good results. And in the meanwhile, while the Western countries were doing that, the Eastern countries, like especially Asan, in South Korea, I actually had the opportunity of spending 3 months there. So these guys, they were very aggressive with their transplant thing. So they were doing for transplants for several years for all patients without extrahepatic disease and without macrovascular invasion. If the macrovascular portal vein invasion was not there and disease was limited to the liver, they were offering liver transplant. So when they looked at their data, and again in their group also, majority of the patients received a pre-transplant bridging therapy, either TACE or microwave ablation, and they also had fairly good results. And when they did the subgroup analysis, again, in their this thing was that the number of tumors, up to 6 tumors, they were doing the transplant, and largest tumor up to 5 centimeters, and no vascular invasion. These patients had a much lower rates of recurrence and comparatively much better survival. It was almost like 80% survival and 20%. So these criteria they were following: largest tumor up to 5 centimeters, up to 6 centimeter, six tumors, and no vascular invasion. And in their subgroup analysis, they also saw that AFP more than 3,000 had a very poor prognosis. So they kept on slightly stretching the criteria. So these are the various criteria in existence. You have the Pittsburgh, Milan, Tokyo, UCSF. So most of the major centers worldwide have their own criteria, have their own set of criteria, which are more or less similar, but with minor changes. So, once this was going on, this is another fairly recent, about 7-8 years ago, when they looked at the data, entire Western multi-center data, Europe, about 56 centers from 36 centers were taken, and they looked at, of course, 75% were within Milan, but they looked at the patients, and 26% were outside Milan. So they've had some interesting results from this data. So the tumor risk plateaued off at 3 centimeters. That is, if a patient had multiple tumors, 1, 2, 3, till then the risk kept on increasing. But after 3, the number of tumors did not matter. Even if the number of tumors was more, if the disease was limited to the liver and no macrovascular invasion, the risk did not increase. So that is, the number of tumors may not be that strong a guideline is what they felt. Likewise, microvascular invasion, if on the histopathology you had microvascular invasion, it doubled the risk of recurrence. So, but of course, that is something which we cannot find preoperatively. Of course, it can be done preoperatively if you do a preoperative biopsy, a true-cut biopsy. But most centers don't try to do a preoperative biopsy for HCC in these patients. Reason being, one is the risk of seeding, and the other being risk of any tumor rupture and bleeding and all that. So most of the time, microvascular invasion we don't know before surgery, but it is a poor prognostic criteria. So they came up with this up to 7 criteria, which is now a fairly widely used criteria. The up to 7 criteria is the number of tumors plus the size of tumor should be less than 7. So when they looked at patients beyond Milan's criteria, but within the up to 7 criteria, and who didn't have microvascular invasion, they had fairly good 5-year survival, 72% 5-year survival. So subsequently, they also the version 2, they've come up with this thing called a metro ticket calculator. So the metro ticket calculator is a very useful thing for us. So it's an online app on which you put the number of nodules and you put the size of the largest nodule, And in fact, there's a version 2 of this metro ticket now. I think year before last, there's a version 2 of metro ticket, which also includes the alpha fetoprotein. So when you put these data based on the various studies and literature available till now, it is going to give us the predicted survival. This is like your patient. Once you feed it, you're going to get the predicted survival of your patient. So based on this, obviously in the LDLT scenario, we based on the metro ticket, you put in your data and you can actually predict the 5 years survival based on the previous experience and have a cohesive discussion with the patient's family, and you can have a better idea as to what is the long-term outcomes going to be when you do the transplant. So this metro ticket criteria has been validated in Asian studies also subsequently. So to summarize, we have the selection criteria. The commonly used are these three. I mean, Milan, UCSF, and up to 7 criteria. And the metro ticket is, again, a very useful criteria to sort of predict the prognosis and have a lucid discussion with the patient. But till recently, most of the thing stick to some basic rules. One is the disease should be limited to the liver. There should be no extrahepatic disease on the imaging, CT chest and PET CT scan. There should be no macrovascular invasion. So any obvious, so micro is on the pathology, macrovascular on the imaging. If there's any tumor thrombus extending into the portal vein, that was a contraindication. A very high AFP is a contraindication. Definitely a poor prognostic factor. What exactly is this level? There is no consensus. I mean, some people look at 2,000, 5,000 also. People look at 500. But so we don't look at the level alone. If we have, like, you're having outside Milan and other factors are poor, and plus AFP is also high, then you sort of disregard the patient. Of course, another contraindication is if there's no evidence of any tumor rupture. And then generally it's been found that tumors in wherever studies, tumors, once they're beyond 10 centimeters, they do poorly. So tumors beyond 10 centimeters is not a recommendation. So these are the criteria. Disease limited to the liver with no macrovascular invasion and with a corroborating high AFP with no tumor rupture. So you have all these criteria to sort of treat patients within the Milan's or UCSF and up to 7 criteria. But what about patients beyond this criteria? So the patients who are outside this criteria, we have found that we can downstage them. So downstage, now you have very good options. Obviously, you have a transarterial chemoembolization, transarterial radioembolization, and microwave ablation. These three, and of course, we also have the new modality of SBRT, just external beam radiotherapy, stereotactic. So these 4 options are there to downstage the tumors. So studies have shown, this is a systematic review, when they looked at patients who were downstaged successfully. So in this, they looked at, I think, some 11 centers, and the patients out of 305, 42 out of 720 who underwent downstage treatment, the patients who were downstaged successfully and then transplanted, their 1 year survival in the various series was ranging from 82 to 100% and 55 to 95%. So all these groups, various groups, showed that in patients whom you can successfully downstage the tumor to within the UCSF or Milan's criteria by preoperative therapy, the people who responded did as well. If they were outside Milan's, they did as well as the patients who were downstaged. So, but the question is obviously, when you have when downstaging therapy, we are not really clear as to should we call it a therapeutic advance or is it just a biological selector. So, is it that the downstaging is actually improving the survival, or because we downstage the tumor, we have a 6-week to 3-month waiting period, and the tumors are responding to downstaging therapy are less aggressive. So basically, we are selecting the better patients. So whatever be the reason, I mean, downstaging therapy helps us biologically select, because if the patient rapidly develops new lesions in the meanwhile, they're poor candidates, and they improve outcomes. So it's definitely a very useful tool for us to use in patients who are outside the criteria. Then the next question that comes is, which is better, LDLT versus DDLT? Cadaveric whole liver graft versus a living donor transplant. One thing is that LDLT is definitely a more ideal option for liver cancer. Reason is, First is there's no competition. So when you have these kind of, now with the liver transplant, the 10 years survival is around 75-80% is the long-term success after the early losses. So when you have this kind of data, there's always a dilemma of doing a limited resource. So like the cadaveric graft is a limited resource. You don't have many cadaveric grafts going around. So how do you use it? We would like to use it for the non-cancer patients who are likely to have good outcomes. And so that ethical dilemma is there in DDLT, especially if you're doing for patients who are beyond the Milan's criteria, etc. But in LDLT, obviously the patient's family member is providing the liver. So there is no competition for that liver. So that way, definitely, I think with LDLT, what has been happened is like, that's why the more aggressive transplant data for HCCs come out from the East. So with LDLT, we can be more liberal. Another advantage for LDLT is obviously there's no waiting period. So it's in a way, it's mainly an advantage because see, once the patient comes in cadaver, once you list in the West, at least in the UK when I used to work, if so the MELD obviously after 16 you list for liver transplant, but the HCC patients, they automatically get a MELD of 23. They get a MELD score of 23, which I think every 3 months it increases by 2 like that. So there is a waiting period. Obviously, during that time, anything can happen. That can metastasize and all that. While in LDLT, moment you see it, you sort of you can go ahead and transplant. That's one advantage. The disadvantage is obviously, again, the moment you see the patient, you're transplanting. While in the DDLT group, you're waiting for some time. So when you wait for some time, there is you can actually look at the biological behavior of the tumor, how new lesions are coming up and all that. The third concern was obviously in LDLT. Can you hear me? Excuse me?
Yes, yes.
Yes, okay.
Yeah,
Okay,
you're
sir.
right.
So the third concern was obviously when you put half the liver in the first 2-3 weeks after transplant, we know that the liver grows very rapidly. It almost doubles its volume. So there's obviously so many growth factors involved. Do these growth factors sort of allow rapid growth, the tumor growth was also a concern. So when you looked at studies comparing both, you had like large, multi-center trials in the West and in the they were not randomized but comparative trials in the West and in Toronto, and the initial, of course, the pioneering centers of Korea. Korea's these hospitals like Asan is the world's largest center for liver transplant. They do around 400 per year. So they actually found that if you see these graphs, the long-term outcomes were better for LDLT compared to DDLT. So this is similar results were seen in the Western studies and in Toronto, mainly, but you can see the differences because of the early. This is the intention to treat analysis. That means it's not from the surgery; it's from when they were decided to list the patient. So the whatever worsening of the outcomes of DDLT, all the drop is there in the first 6 months, only in the first 6 months. Subsequently, these two are almost running parallel to each other, as you can see. So LDLT has better outcomes than DDLT, but this is mainly because of the early dropouts, deaths in DDLT during the waiting period. So essentially, the rapid growth of the graft is not a factor, and both DDLT and LDLT have similar outcomes. So, like I said, in East, in fact, like in Korea and Japan, compared to almost around 50 to 60% of their liver transplants are done for liver cancer only, because they have a huge burden of hepatitis C, hepatitis B. That's what I noticed in Japan also. That's why they're really big pioneers in liver surgery. So it's predominantly LDLT. And like I said, their practices are slightly different. They are more aggressive than the West, which is predominantly DDLT. So the extrahepatic disease is definitely a contraindication. There is no confusion in that. I mean, if they have disease beyond the liver, we never transplant. The number of tumors, if the disease is limited to the liver, is not a criteria in the Asian countries. Then, if they look at gamma carboxyprothrombin and AFP, if these levels are high, so especially for example, in the setting of a portal vein thrombosis, so once people started getting results with 5 centimeter tumor, then bigger tumors and increased number of tumors, they also looked at why not for portal vein thrombosis. I mean, when the tumor thrombus in the portal vein. In those patients also, if the tumor markers AFP plus DCP level is less than 300, then they found that they can still, if AFP is less, if portal vein with macroscopic portal vein thrombus, if AFP is less than 200 or AFP and DCP less than 300, still these Asian centers they do transplant even for patients with macroscopic portal vein thrombosis. But obviously they get downstaging therapy to look for give them a small time period and also control the tumor growth during that period. That downstaging for macroscopic portal vein thrombosis ideally is done by SBRT. So in addition to till now we've been looking at size, we know, number we know, AFP level we know, then any other prognostic factors, which we, of course, response to neoadjuvant therapy, we know, downstage therapy. Any other prognostic factors? Now PET-CT is a very accepted preoperative prognostic factor. So in the the Taiwanese study, which is subsequently validated at UCSF, also in another study at UCSF, the PET-CT done pre-transplant in the multivariate analysis, the FDG avid tumors had a poorer prognosis compared to the non-avid tumors. So in their study, the size of the tumor, the presence of microvascular invasion, and FDG avidity more than 4.8, these patients had a worse outcome. So doing a preoperative PET for HCC, especially if they're beyond criteria, and if they are both beyond criteria and they are FDG avid tumors on the PET, it would look like they're not good patients for liver transplant with a high risk of recurrence. So subsequently, the Seoul University and this is the NCC and National Center for Cancer in Korea. Their criteria they looked at patients. So they at 546 transplants, they analyzed the disease-free survival at 1 year was 85%, and 5 years was 75%. And they're doing their analysis. They came out with this sort of criteria. In addition to the when the patients are outside Milan's, you can put them into low risk, intermediate risk, and high risk group based on two things: AFP and PET level. So the AFP less than 200 and PET negative, the disease-free survival was 86%. While if the AFP is more than 200 and PET is positive, disease-free survival either or. I mean, one of them, either AFP more than 200 or PET positive, disease-free survival is still pretty good, 79%. But when both AFP more than 200 and PET positive are positive, then the disease-free survival is very poor. So, I mean, so when you look at all this, so when you have in our setup, based on so much of wealth of data we have, currently it looks like patients who are outside the criteria, within criteria, there's no confusion. If they're outside the criteria, we can use things like PET-CT and AFP levels to identify which patients are at high risk and which patients are at low risk. And the patients at high risk, obviously, either we don't offer them transplant, or if they're still keen, we offer them downstaging therapy. And if we see the response, and then we go ahead. So the NCCK Korean criteria, their criteria, exactly like I said, the patients outside, if they're not FDG avid, and total tumor should be less than 10 centimeters. So once all this came, the next question was for tumor thrombus. So for tumor thrombus also, studies have, normally all these years, it's been like an absolute contraindication. A tumor microscopic portal vein thrombus of the tumor is a contraindication because it's already invaded into the blood and it's gone beyond. So it used to be a contraindication. But the Eastern countries, they were pioneered in this. In fact, there's an important publication from our Medanta, which is again now developed into one of the highest volume centers in the world. So in the Korean studies in 2007 from Seoul University, they showed that, so you have to differentiate between segmental versus lobar. So patients with segmental, that means, segment 7, segment 8, versus lobar means right portal vein thrombus, left portal vein thrombus, main portal vein thrombus. Selected patients, so in the segmental thrombus for tumor thrombus, patients in whom AFP is less than 200, less than 100, their outcomes were excellent. So it's not like macrovascular tumor thrombus is a strict contraindication. If you have only a segmental thrombus and you are able to achieve a good AFP level after downstaging treatment, but mostly by SBRT, you can have excellent long-term outcomes. So even the Medanta study showed that portal vein thrombus patients with good liver function, obviously you can't give radiotherapy if the bilirubin is very high. So bilirubin less than 5 and no ascites, they received SBRT. In the initial part of their treatment, they gave 50 to 60 gray SBRT, and response evaluation was done at 4 to 6 weeks. And in the patients who were downstaged, 25 out of 43 patients were downstaged. They had fairly good, acceptable recurrence-free survival. I mean, this is obviously not as good as within millions, but any 5-year survival of more than 50% is considered good enough for HCC. So, in fact, now I think they are following, like, they give the radiotherapy and 2 weeks later, they sort of reassess. And how they reassess is obviously by PET, FDG avid becomes less FDG avid, or on the CT, there is absence of enhancement of the tumor thrombus after radiotherapy. So, SBRT is now the standard of care, established as standard of care for macroscopic tumor thrombus, because the TACE and TARE, they don't really work very well with the tumor thrombus. And in their study, they also found that an absolute AFP value less than 400, or AFP after treatment, if it drops more than 2000, it is a better response. So to summarize, basically, I mean, not to get confused too much, but vascular invasion may not be an absolute contraindication as thought previously. The technique of transplant is also slightly different. I mean, again, we go by the no-touch technique. What we initially do is basically we sort of, this is again developed by the Koreans. The portal vein hilar dissection is done, and the portal vein is divided and shunt is done. So you don't avoid mobilizing the liver in the initial part. Initially, you do this, you don't need to touch the liver for that. You do the dissection, do the shunt, and then with minimum mobilization, you clamp the left and the right, left and middle trunk and the right portal vein. So once you do that, only then you start mobilizing the liver segment. So that kind of a no-touch technique is useful in HCCs. Another important finding, as people kept doing more and more volumes, is normally we think that recurrence after transplant, it's obviously a very poor prognosis, because these patients are under immunosuppression, and then they tend to behave very aggressive, the recurrence. But a lot of these recurrences may be salvageable. So in the Korean studies showed that 92 patients recurred. 1, 3, 5-year survival was 60%, 23%, 12%, which is still, I mean, after recurrence, 1 year, so these are fairly good results. So even if in patients who recur, management of recurrence may prolong survival. Of course, an important factor, we have to consider is obviously the cost in our Indian setup. I mean, these are all, insurance and government-sponsored programs, and the cost of treatment, expensive treatments like TARE and all that, may not be feasible in our country for everyone. So that's a factor we have to consider. So, basically, the international consensus as well as the INASL consensus says that now it's clear cut that tumors, LDLT may be offered after discussion with the patient's family and the patient. It may be offered to tumors beyond accepted criteria. The correct threshold, we still don't have a consensus. It is selected on a case-to-case basis. I mean, what is the exact size? We know that, okay, more than 10, but between 5 and 10, what size we select? It's a corroborative. You can use PET, you can use AFP levels and all that. And but for DDLT worldwide, I mean, there is no option that, if your patient, because it's a limited resource and you can't experiment with it. For DDLT, the Western world and in India also, they have to stay within the criteria. So, yeah, and then, of course, once you do the transplant, we'll briefly talk about the perioperative management for HCC. So, the surveillance is, most of the recurrences, in fact, almost all the recurrences develop within the first 2 years after transplant. After 2 years, the likelihood of recurrence is so low that, in fact, if another cancer develops after 2 years in the liver, we should really consider that is the liver graft failing, and cirrhosis with de novo HCC should be considered. So the initial follow-up is 3 months, at 3 months, then every 6 monthly for 2 years, and yearly once till 5 years. Obviously, we do the tumor markers. I mean, not just AFP, but PIVCA also correlates very well. PIVCA is also available, actually. We can also getting it done for some of our patients, and DCP, these tumors, and selected patients. So selected patients meaning when you have AFP levels are going up, but the imaging does not show up anything, you can do PET CT scan and bone scan. And like I said, early recurrences are poor prognosis, while late recurrences, the longer the gap between your transplant and your recurrence, the better the prognosis, and they can be salvaged with other treatments like TACE, microwave, RFA, and all that. And then coming to the immunosuppression, basically, the common sense wise, the natural killer cells and the T cells, they do the immune surveillance. So they, in our body, all of us, we have mutations can lead to abnormally proliferating cells, but the natural immunosurveillance of the body, sort of the innate immunity, destroys these abnormal cells and destroys the circulating cancer cells and prevents the spread of cancer. So in fact, many of the cancers, the mechanism is by they secrete interleukins and other factors which suppress these NK cells and T cells and promote their dissemination. So the concern is especially in the transplant, especially in the first 3 months when we give a slightly higher dose of immunosuppression, is this immunosuppression going to promote the cancer growth in cancer patients? So the studies have looked at this. So steroids is very difficult to study because now they're such an integral part of any transplant immunosuppressive protocols that you cannot afford to stop steroids and look at the benefits of stopping steroids. So steroids have been difficult to study and their effect on the cancer cells. But we have clear-cut data on other areas. So calcineurin inhibitors, that is the tacrolimus and the cyclosporin, how they work, they inhibit calcineurin phosphate enzyme that reduce the IL-2 secretion, and the IL-2 is responsible for T cell growth and proliferation. So these calcineurin inhibitors reduce the T cell proliferation. They reduce they are the drug for liver transplant, the most important drug to reduce the rejection. And studies have shown that high levels of CNI have higher recurrence rates. So generally also we maintain between 8 to 10, and patients who had more than 10 level of TAC levels, the trough levels more than 10, they sort of had higher rate of recurrence. And so general thing is that CNI should be in the first 3 months should be less than 8, and 5 to 8 afterwards is the standard in these cancer patients. Luckily, the anti-metabolites, that is azathioprine and mycophenolate, in studies they've had no significant effect on cancer growth. On the other hand, the mTOR inhibitors, like you have sirolimus and everolimus, they are the serine threonine inhibitors. So the mTOR inhibitors. So mTOR signaling is a way of, again, it sort of promotes cancer growth. By the mTOR signaling promotes interleukins and leads to cell proliferation in 60% of the HCC. So obviously, when mTOR signaling is involved in cell growth, the inhibitors can have a beneficial effect. So studies have shown that sirolimus and everolimus have potential anti-cancer properties. So meta-analysis have shown that they can decrease the HCC recurrence and improve the outcome. The problem with these drugs is that they cannot be, they're not very effective anti-rejection treatment, as effective as tacrolimus. So that's why there was a large multi-center trial, the Silver trial, which compared mTOR free versus with mTOR. It didn't show any benefit. The problem is the mTOR receptors usage is giving benefits in terms of cancer survival, but because of other problems, rejection and its treatment, patients were being lost. So mTOR cannot be used as a standalone immunosuppression, especially in the first 4 to 6 weeks, because they have poor wound healing and the chance of rejection increases. So basically, right now, if you have patients outside criteria and patient, if you have any post-op, if the AFP hasn't come down and you're worried about risk of recurrence, the high-risk patients, the ideal strategy is in the early post-op first 2 to 3 months, minimize the CMI. Obviously, you have to give CMI for the first 1 month. I mean, instead of 8, you maintain around 5-6 levels and introduce mTOR and mycophenolate. So you can add these two and then rapidly taper off the CMI after the first thing. So in the long run also, we need a very low dose. You can maintain 2 to 4 CMI of tacrolimus and use this everolimus, sirolimus to reduce the tumor proliferation. So, I mean, in the future, not in the future, in fact, even probably now, molecular studies like you can look at the tumor pathways. I mean, they've looked at the mTOR hyperactivation gene. If the tumor cells on the molecular analysis, they show this pathway is active, you can use the mTOR. If they show the IMP-HDG enzyme, if that is hyperactivated, you can use mycophenolate. So molecular studies may help us tailor the immunosuppression according to the patient. So to conclude, basically liver transplant is obviously an excellent option for HCC in liver disease. And as you've seen in the data, it can be offered when you, especially for LDLT, you can offer it for patients beyond beyond the Milan's criteria in selected patients by taking multiple factors into the picture. We can be offered to patients beyond criteria. Thank you.